Uterine fibroids are benign non-cancerous growths that develop in the wall of the uterus. They occur in 30 to 70% of women and are particularly common in Afro-Caribbeans. Fibroids may cause abdominal swelling, heavy or prolonged bleeding, and pressure symptoms on the bladder and bowel. Not all women with fibroids require treatment. Treatment is usually reserved for women with heavy periods, anemia, and pressure symptoms. Traditionally, surgery was the treatment option available for these women with fibroids. Luckily, there is a minimally invasive treatment option available called fibroid embolization that targets the feeding arteries of these fibroids. The patient is fully awake and the procedure is relatively pain-free with little or no downtime. Joining us today is Dr. Nigel Hacking, one of the pioneers of this revolutionary treatment. He will share with us his expertise on fibroids and fibroid embolization so that you can make a more informed decision about your treatment. Want younger-looking skin and a strong immune system? Vitamin E is a powerful antioxidant that keeps your body healthy from the inside out. Protects cells, prevents aging, wrinkles, and cell damage. Boosts immunity, helps fight infections and keeps skin healthy. Supports heart health, improves circulation, and prevents blood clots. Where can you find vitamin E? Nuts and seeds, almonds, sunflower seeds, and hazelnuts, avocados and spinach, nutrient-dense and packed with vitamin E. Olive oil and fish, great sources of healthy fats and antioxidants. Low vitamin E can cause dry skin, weak immunity, and muscle weakness, but getting enough keeps you glowing and strong. Stay youthful, stay healthy. Add vitamin E to your diet.
Before you take your omega-3 supplement, check for the natural product number NPN on the label. This unique code shows that Jameson products have approved rigorous Health Canada testing for safety and effectiveness. Unlike some supplements that carry disclaimers like not approved by the FDA, Jameson Omega-3 is the trusted choice, offering 1800 milligrams of EPA and DHA for heart health. Choose quality. Choose Jameson.
My name is Dr. Joanne Williams-Carroll, and I am the Director of Behavioral and Mental Health at the Community Hospital. At the Community Hospital, we believe in nurturing mind, body, and soul. Through our counseling and chaplaincy program, we will provide you with support and strength you need to help with your mental and emotional well-being. Give us a call.
The Community Hospital of Seventh-day Adventist,
where good private health care is affordable.
So let's get straight to it. We're talking today about uterine fibroids, and uterine fibroids are the most common benign tumor in the female reproductive system, and they're commonly found in young women between the ages of 30 and 50, and they're very, very common in the Caribbean. Before we even begin, Dr. Hacking, can you tell us exactly what are uterine fibroids? It's a very, very common tumor.
They are common, and as you say, particularly in Afro-Caribbean women, but also in other races as well. And we don't really know what causes them, but we know there's a genetic predisposition. And we know that the higher the estrogen level, the female hormone, the faster they grow, the bigger they grow. So during pregnancy, they grow. And after the change, after menopause, naturally, as estrogen levels drop, they shrink away.
Right. And these fibroids, they're really just overgrowths of the muscle fibers in the uterus, and they're quite benign.
Completely benign. They do
Not
not turn
cancerous
cancerous
at all,
no.
but they can produce some troublesome problems, some symptoms which could affect quality of life. And how can they present? If a woman has fibroids, how would that look?
The most common presentation are menstrual disturbances, so prolonged and heavy and often very painful periods. So rather than a fairly normal 5-6 day menstrual cycle period, they might get incredibly heavy bleeding for 2, 3, 4, 5 days, and it might be prolonged to 7. Mm-hmm. This bleeding month on month on month can then lead to a drop in the hemoglobin levels and anemia, which can be very tiring. They can also be very painful. Some women will bleed constantly and not have a cycle at all. They'll bleed for 30 days, 40, 50, 60 days.
Right.
So that's the main symptom, but also as they grow bigger and bigger and bigger, they'll press on other organs, particularly the bladder, and to a lesser extent the bowel, the rectum. So they often produce urinary urgency, frequency, having to get up at night. And at some stage they can be so big if women leave them a long time that their friends will say, when are you having the baby? They can really look full-term pregnant.
Yeah. So pain, heavy periods, clots with the periods.
Commonly,
Very
yes.
common.
Yeah.
Painful periods, painful intercourse.
Indeed.
Now, you said that they can even, if they're large enough, can displace or compress bowel. So constipation, I would imagine, would be another common feature. And as you said before, they're very common in Afro-Caribbean.
Very common.
Right? So we see it. I mean, I see fibroids on a daily basis. So it's very common. It can affect women's quality of life. What would put a woman, besides ethnicity and genetics, what can put a woman at risk of developing uterine fibroids?
It's very difficult to know that. A lot of women are presenting also with infertility or multiple miscarriages.
Yeah.
So some of the fibroids can block the tubes, and because they distort the cavity of the womb, they can stop implantation, so a woman cannot get pregnant, or if she does get pregnant, it can lead to miscarriage.
So there are things that we could do. Now, not every woman with fibroids are going to have all these symptoms that we described, but there are women out there with the heavy periods, and as a result, their blood count, their hemoglobin is very low, they're very tired all the time, or they're living in pain. And there are definitive treatments that are available, which is why I asked you to come on the show to talk to us about, in particular, one of those treatment options. There are about 3 definitive treatment options for them. And the one that you are here to talk to us about is about fibroid embolization. Big word. What exactly is that?
So an embolus is something that flies off and blocks off a vessel. So most people have heard of a deep vein thrombosis or DVT, and occasionally a clot can fly off to the lungs. That's called a pulmonary embolus. So embolization is a medical term for deliberately blocking off a vessel. There were some, I'll just briefly mention some of the traditional treatment, surgical treatments. If medical treatment fails and the woman is still symptomatic, a gynecologist can cut out some of the fibroids. They can rarely get all of them, but some of them. That's called a myomectomy. It's an abdominal operation, a myomectomy. Now, there's a lot of blood loss with that because these are very blood-rich, benign growths. And there were some Jehovah's Witnesses in France that needed to have their fibroids removed with myomectomy because they wanted to get pregnant. They'd had miscarriages. And the gynecologist felt, well, we can't cut these fibroids out, do a myomectomy, without the need possibly of having to give a blood transfusion. These were Jehovah's Witnesses. They said, well, that's against our religion. So that gynecologist in Paris in the mid-90s asked a radiologist like me, an interventional radiologist who does minimally invasive surgery, to block off the blood supply to the arteries on both sides to try and reduce the blood supply so he could cut out the fibroid. So that's what they did, and a month after the embolization procedure, they cut out the fibroid, but it was already dead. And to his credit, he said, well, we've cut it out. It was safe. We didn't need a blood transfusion. But maybe we didn't need to cut it out. If we'd just been a bit more patient, we could have allowed nature to take its course, and that fibroid would have shrunk down over the next 3 or 4 or 6 months, and the symptoms would have gone, and the woman wouldn't have needed the myomectomy. So that's how fibroid embolization started.
So in fact, and you're being quite modest here, you kind of glossed over your history. You're one of the pioneers of fibroid embolization. I was reading your bio. You started this procedure since 1997, and when I did my calculations, that's 28 years of doing this procedure. And a lot of the viewers out there would be very confused, wondering why is it interventional radiologist is here talking about a gynecological issue such as fibroids, and that's the beauty of radiology. I'm a radiologist, and I've got to say the beauty of radiology and interventional radiology is where you can marry imaging with surgical interventions and target your treatment. And you were talking before about the different options, myomectomy being one option a woman may be offered. There's hysterectomy. And hysterectomy and myomectomy, these are the traditional surgical options that patients have been offered in this country and in the Caribbean. But there are some drawbacks to having these particular procedures, right? Agreed?
Agreed.
And sometimes, not every, like you say, a patient, like a Jehovah's Witness patient who cannot accept blood transfusion, those options are not viable options for them. But other situations would make, let's say, hysterectomy not very pleasing, not very, not the best option for a patient. Let's just discuss. I mean, like, when would let's say you have a young female with uterine fibroids that are producing symptoms, the pain, the heavy periods, the clots, can't go to work, missing work, can't function properly at home, but she still wants to have a family. What does she do? She can't do the hysterectomy because she still wants to have a family. So she's myomectomy versus uterine embolization, fibroid embolization. What would you suggest?
Well, you say I'm a radiologist, but I'm a clinical radiologist and a minimally invasive surgeon. So I run clinics, and young women do come to me in the UK and out here and in Africa. And I look at each case individually. If that young woman is not ready to start her family and she has a solitary fibroid, say, then I think a myomectomy is probably a good operation for her. But solitary fibroids are quite rare. Most women, if they have fibroids, have multiple fibroids. So with myomectomy, they can cut out the fibroids at the front, they can cut out the bigger fibroids, but they leave behind the small fibroids. It's no criticism of the gynecologist, it's just you can't see them when you're doing the surgery. And those fibroids will regrow. So recurrence after myomectomy is very, very common. If women have multiple fibroids, it's almost invariable that some fibroids would regrow. Yeah. So that's where I would say if there are multiple fibroids, embolization is a really good option. Now, a lot of gynaes will say you can't get pregnant after embolization. Yes, you can. And I've done lots of studies over the years looking at ovarian function after embolization of the uterine arteries, the fibroids, and it doesn't affect ovarian function. Quite often, though, the ladies that come to me are in their late 40s. They say they'd like to get pregnant, but with the best will in the world, I can't make them more fertile. I can treat the fibroids. So I would encourage women, certainly in their 30s, who've got symptomatic fibroids, and possibly even in their late 20s, to consider fibroid embolization. And I'd be happy to see them.
Fibroid embolization, we haven't really, so can you guide us as to what exactly, what a patient would be experiencing? What does the procedure entail? It's from the time you see them and they're on the table, what exactly does that?
So it's a procedure that is painless. It's painless to do the procedure. Therefore, you don't need a general anesthetic. However, it's in a hospital environment, everybody gets anxious. So we give our ladies some sedation. Right. And if they want a lot of sedation, we'll give them a lot of sedation. If they want a little, we'll give them a little. That's their choice. A little bit of local anesthetic in the sort of groin crease, usually on the right side. And then I make a little, well, I don't even make a nick, I just put a little needle in And the catheter goes in. It's a little plastic tube. It's long. It's 60 odd centimeters long, but it's only
thin.
1 millimeter thin. So
Yeah.
we don't have to make a cut. And there's no stitches. There's no cutting. Using radiological techniques, we can see and guide that catheter all the way from the right side into the left side of the womb artery, get some pictures to confirm I'm in the right place, and then put a little embolic particles. Now we can use plastic particles or we can use gel foam or gelatin sponge. I tend to prefer the gelatin sponge because it will dissolve within a few days, but it kills the fibroids within a few minutes.
Right.
When I finish doing the one side, I bring my catheter back onto the right side, do that. The whole thing takes me about 20 minutes, sometimes half an hour. We pull the sheath out, they go up to the ward. Now, the fibroids will start to die within 15 or 20 minutes.
Because you've cut out their blood supply.
Cut out the blood supply. The blood carries the oxygen.
Yep.
Just like every organ, it needs oxygen, so they die off. But the womb doesn't die. So the womb survives, the fibroids die.
So this is targeted
Absolutely
treatment.
targeted.
Okay.
Absolutely targeted. There can be some pain after the procedure, so we give local anesthetic, not only into the groin, but directly into the womb. And we give various painkillers, mild, medium, and strong painkillers. And the patient goes up to the ward with what's called a patient-controlled analgesic pump. So they press a button, get some painkiller. I then come and see the patient the following morning, and the vast majority of women will have mild to moderate discomfort, which will last probably for 5 or 6 days, so they'll go home on painkillers and antibiotics. Occasionally we need to give a little bit more painkiller and keep a patient another couple of hours. But once we're on top of the discomfort, they can go home.
So they go home the next day.
They do.
So compared to hysterectomy, myomectomy, which require general anesthesia because they're painful procedures and quite invasive procedures, embolization is not. Patient is fully awake and goes home the very next day, as opposed to spending 3 days, 4 days sometimes after a hysterectomy. That's one. Two, it's, as you say, minimally invasive. This is like just threading a small tubing into the patient. Blood loss, minimal.
No blood loss.
No
so
blood
I
loss
don't mind
at all.
if the lady is anemic when she comes in, whereas if you're anemic before a myomectomy, they would need to transfuse up.
That's interesting. So
I have no concern.
in terms of contraindications for this, are there any contraindications?
I think if a woman had an active cystitis or an active infection, then I think we'd want that to settle down. We don't want bugs in there when I do it.
Right.
But that's very rare.
Yeah. Okay. And of course, you're not putting her to sleep, so there's no contraindications to that. There's no downtime, minimal downtime. If one of my patients I see is young, in her 30s, wants to have babies still, and opts for fibroid embolization, does it, how long can she then start to have a family?
I would usually say leave it to settle down for probably about 6 months. I like to see all my patients for follow-up at 6 months. I like to see that their symptoms have settled, and they usually will within a month or two.
Right.
And their periods will have returned to regular and normal and light and painless. The tummy will have gone down. We'll have done a scan to check that there's been a good shrinkage. And then I would say, okay, now you can try. So to be on the safe side, I would say 6 months. I did have a woman who ignored all that and was pregnant 2 months later, and it was all fine. But I think there would still be a slightly higher risk of miscarriage. So let's let the fibroid shrink down for 6 months.
Let's have some healing
I think
first.
so. I think so.
And can she have normal vaginal delivery or C-section?
She doesn't need a C-section, so
Wonderful.
she can mostly have a normal vagina.
Amazing.
If she's had a myomectomy before,
Yeah.
then that would be the decision for the obstetrician, really.
Yeah.
Because the scar from the previous myomectomy might make it a little bit more difficult. But normally, a woman could have a normal vaginal delivery.
And of course, for me, as a doctor advising patients, a common question they ask is money. How much does this cost? And I think that's a pertinent point that we need to bring up. I mean, let's just talk about how much does this cost?
Well, we try and keep all the inclusive costs. I do this, Fibroid Caribbean will do this at St. Clair Medical. I've done it in other hospitals, but that's our preferred option. And we'll keep it under 40,000 for the foreseeable future. I think it's 36,000 at the moment, but there will be pressures from the hospital, the cath lab, the consumables we use. As they go up, it might creep up. Right. But I believe that's considerably cheaper than surgical options.
Right. So, I mean, compared to hysterectomies, which will start at 60,000, myomectomies start around 40. So we're looking at definitely an option that young women need to be aware of, to ask their healthcare providers. Yep. And is there anything else you'd like the women out there to know about fibroid embolization?
Well, I think just that I work very closely with quite a small number of gynecologists who have great experience of fibroid embolization. But I've also worked with some that whatever anybody else says, they will want to do hysterectomy. And for the woman to not always take either what I say or what their gynecologist says, but to research it themselves and to be open-minded and to look for choices, really. I
agree. So educate yourself. And this is the whole purpose of me inviting you here today, is to empower women, enable them to be more aware that there are other options available to them if they have symptomatic fibroids, and if they're young and they're looking to have a family. Myomectomy, hysterectomy are not the only options. We have fibroid embolization. So Dr. Hacken, we're running out of time, but before we go, like I ask all my guests, if there is one thing that you'd like to leave with the viewers out there about fibroid embolization, what would that be?
If you want to get back to normal quickly, you will do so with fibroid embolization more than open surgery. So at least think about it and ask about it. And I've been coming here for over 25 years, and I want to continue to come here and offer this service.
Thank you very much.
Thank you for inviting me.
Before you take your omega-3 supplement, check for the natural product number NPN on the label. This unique code shows that Jameson products have approved rigorous Health Canada testing for safety and effectiveness. Unlike some supplements that carry disclaimers like not approved by the FDA, Jameson Omega-3 is the trusted choice, offering 1,800 milligrams of EPA and DHA for heart health. Choose quality. Choose Jameson.
I am Dr. Delphina Ovid, your friendly neighborhood dentist. At Community Hospital Dental Clinic, we offer examinations which include x-rays, basic oral cancer screening, and a treatment plan. We also offer cleanings, fillings, extractions, root canal treatment, and complete and partial dentures. Remember, you don't have to brush and floss all your teeth, just the ones you want to keep.
Give us a call at 235-5479.
The Community Hospital of Seventh-day Adventist,
where good private health care is affordable.
So if you're strapped for time and you need to prepare a quick meal, here's a lovely idea for you. And it's all done by Chef Emmanuel from Food Hall. It's called spinach and egg salad.
Thanks, Doc. something very important. There is an intrinsic neurotrophic factor that is released through myokines, that is some peptides that we have in our muscle that producing neuromodulation and increase that peptide in the brain to increase the neurocognitive of the brain.
I'm glad you said that. Right. So exercise has an important part to play in the aging brain. As we get older, our gray matter does shrink. We have reduction of synapses, but exercise is shown to actually improve our cognitive functioning.
Totally.